Great. Hello, everyone, and thank you for joining us today for our webinar, Fix Your Reimbursement Flow, How High Quality Data Optimizes Claims. My name is Alice Keel, and I'm part of the marketing team here at IMO. So before we get started, I just want to take care of a few housekeeping items for those of you attending. So first off, this webinar is being recorded, and it's going to be available to you for future viewing after the session. And then throughout the session today, all attendees are going to be in listen-only mode. If you have any questions, please go ahead and type them into the questions section on your GoToWebinar console. At the end of the presentation, we will have a Q&A session as well. And we will try to get to as many questions as we can, but if for any reason your question is not addressed on the call, someone will be able to follow up with you afterwards or after the presentation. So today we have two presenters with us. Dr. Andrew Cantor, former CMO and Senior Advisor to IMO, along with June Bronner, our VP of Global Clinical Services. We have a few items that we're going to be covering on the agenda today. One, challenges with point-of-care documentation, impacts of imprecise coding, common approaches to address this, and finally, solutions to improve data capture and cleanup. So as I mentioned before, if you have any questions or comments while our presenters are speaking, please go ahead and type them into the questions on your GoToWebinar control panel. I'm now going to pass it over to Dr. Cantor to get us started.
Hi, everybody. My name is Andy Cantor, and I'm really happy to be talking to you today about this pretty important topic. And I'm going to try to begin with giving a little bit of background, not just about who IMO is and why we're talking about this particular topic, but also give you some context and to tell you a bit of a story about how we've got to where we are today. So, and June will be chiming in for my slides, and I'll be talking when June is talking as well. So first of all, why IMO? And if you don't know about who we are, we've been around since 1994. We actually, started out as a company that was developing electronic health records, and the Allscripts professional product really was our EHR when we first started. But we very quickly became involved with enabling the use of electronic health records, and are now developing clinical interface terminology and terminology services to improve the quality of data across the entire health ecosystem. We've been doing it now for, since, like I mentioned, 1994, but we're essentially ubiquitous through the healthcare system. There isn't a major EHR that doesn't use IMO to collect at least the conditions and problem terminology. And that we're in more than 4,500 hospitals. There are about 90% of physicians in the United States touch IMO in one of their clinical encounters or when using the EHR. And in particular, within the Cerner install base, about 95% of Cerner implementations use IMO, at least in some part of the documentation process. So we've been doing this for a long time, and we've been very much focused on not just the capture of the data, but ultimately how that data is going to be used. Today's focus will be on revenue cycle in particular, but that we understand that really all of the data that's being captured within the health information ecosystem is important, and it is really the foundation of all of the kind of things that we'd like to get out of our electronic health records and information systems, whether it's revenue related, but also as we want to focus on improving quality of care, feeding back into the health system information and data about how care is being provided, how outcomes are being provided. And then ultimately, as we've learned within the recent pandemic response, this data is really important for how we respond in the case of pandemics, and our research and life sciences community is very much focused on the data that that's captured through electronic health records, and as well as other aspects. So this is going to be something that we're going to focus on specifically today, but I hope you'll recognize that not only is the revenue cycle important, but that the same kinds of concepts that June and I are going to be talking about are really very much fundamental to the many of the other things that we hope to get out of our information systems. So let me start with giving some background. And since IMO really began in the mid-90s, I can go all the way back to the beginning, which for us was when most of the electronic health records were essentially an administrative tool. They were kind of extensions of the practice management system, and that the folks actually who were using the system were not the clinicians, or not the point of care. And that this was the environment in which electronic health records began. And if you can think of them in some ways as kind of glorified super bills, there was very little kind of difference between the data that was being collected through these systems and the revenue cycle, because that was kind of what they were intended to do. But it was in the 90s when clinical interface terminology first began to become important, and it really allowed the clinicians and physicians to think and document in their own language. And so whereas before they really couldn't recognize a lot of the language used in the information system, now suddenly the diagnoses and the terms and things that they needed to document were there. And this really allowed them to become users of the health systems, the electronic health records, and essentially brought them into the care documentation process electronically in a way that was before this primarily done through somebody else in the office. Now, there was a lot of scrutiny then on whether the data that was being collected in these electronic health records actually matched what was being billed for. And so there was an additional level of requirement and attention placed, but it really wasn't until the mid 2010 with the HITECH Act, when there were a lot of incentives put in place around meaningful use to say that clinicians needed to use the electronic health records, that the data that was going to be collected in electronic health records needed to meet certain standards. There was a need for a lot of additional coding, not just the reimbursement codes, but things like SNOMED and LOINC and so on. And so this really brought a huge amount of attention to the point of care, to the electronic health record, and to what was being documented. And so unfortunately, though, what this often did was create a lot of incentives for collecting data that was not what the physicians necessarily needed to do to take care of patients, but was how this either the financial systems or the quality measures were going to be put in place to evaluate the health systems. And so this was the sort of the beginning of the challenge that was happening, which was there was kind of a deviation. I'll talk a little bit more in a minute about between what the clinicians wanted to document and what the health systems really needed to document to get paid. Where we are today really was with the introduction of the 21st Century Cures Act was sort of a further evolution of this process. And so not only was now the health system expanded to include patients and the focus on patient-centered data, and interoperability, where the data no longer could be held in a single silo, but needed to be able to be made available to other people within the system, that quality of that data really became critically important. And then, the 21st Century Cures Act came out literally in March of 2020 when the COVID-19 pandemic hit. And so there was a huge focus on utilizing that interoperable data for population health and surveillance around the pandemic. But it's, for the next several years, you can anticipate now that there's going to be a huge amount of focus on leveraging this data. Now, one of the things that it also sort of brought to the fore was this focus on value-based care. And although we're not going to sort of emphasize that as much today, this is an important direction that NCQA and others are moving in, which is to essentially realign clinical documentation with the way we get paid. And so we're very much interested to see where that's going to go. But for now, what we're going to talk about is how this evolution in incentives and compliance requirements and payment models has really challenged the users of health information systems, and particularly electronic health records.
And I would also add, you have the highlight the ICD-10-CM transition and the challenge of as the industry standards and for ICD particularly advance, and how there can be challenges related to how that system is classifying along the way. To really leverage the systems and the importance of that and ensuring to capture all the information, and how that will feed into the other areas that Dr. Cantor was speaking around, especially around value-based care.
Yeah, June, that's a really important point, because when they went from 15,000 codes to something like 80,000 codes, and then many of the ICD-10 requirements necessitated additional information, kind of pushing the physician beyond what they might normally have documented, really was a significant challenge. And as we get into the revenue cycle, many of the interactions that are occurring have to do with that lack of specificity or missing data in the documentation. And we'll be talking about how technology potentially could play a role in easing that process, as well as obviously improving the right coding of the data. So I'm going to talk about this struggle to capture clinical data. So like I talked about at the very beginning, was that there was this difference between what revenue cycle and quality measurement needed in terms of certain standard codes, many of those being non-clinical, and what the physicians were trying to do, which was take these complicated patient problems, or what they were trying to accomplish in their workflows, and that there wasn't a one-to-one alignment. Unlike in the early days when we were simply dealing with ICD-9 diagnoses and super bills, this was suddenly now a lot more complicated content that needed to be captured. And there was this gap between what physicians were capturing, or the kind of language that they were using, and the standard codes that were necessarily coming out to drive these other workflows. So what ended up happening was, physicians would be documenting using languages that they were familiar with, and clinical interface terminology, sort of allowed them to capture that information. But on the other hand, on the back end, as the HIM folks were trying to utilize that data for at least the revenue cycle, but more and more as we were getting into clinical research and so on, the people who were taking secondary use of data, that they were seeing not the same types of codes, and certainly not the ones in sufficient frequency or quality to generate good revenue cycle. And so this led to this rather iterative cycle that I think many people are familiar with lots of interruptions and feedback back to the clinicians, and sort of saying, hey, what you're putting in the EHR isn't what we really need, or we think that there might be gaps in that data. You're not providing specific enough information, or maybe there was additional information that was related to this particular problem or procedure. And this became really annoying, both to pretty much an inefficient cycle that everyone was unhappy with. And so one of the things that we're hoping to talk about today is, how the appropriate use of technology can really eliminate many of these burdensome communication loops, and provide better quality data, not just for the revenue cycle folks, but really for everybody who wants to use secondary data. Yep. So I'm going to turn it over to June now, and she can talk a little bit more specifically what some of those challenges were.
Yeah, thank you, Dr. Cantor. And along those lines, we'll start with looking at the right-hand side around specification. And, just to continue on the theme of around the feedback cycle, and as we had mentioned earlier, the transition to ICD-10-CM, and where there was additional specificity or new specificity for that. And so as the clinicians were documenting, however, it's the specificity that ICD-10 is thinking about, not necessarily what the clinician is thinking about. So there are, some examples, as you can see here, around asthma and heart failure, so different types and stages along that they are key to capture that. as well as then to be able to assign the appropriate codes for all the downstream impacts that we're going to talk about, but most specifically around the revenue cycle. And how can we leverage technology to support that? But another key piece of clinical documentation is really the what is termed clinical validation by CMS and Centers for Medicare and Medicaid. And this came about within the Recovery Auditor Scope of Work contract from around 2011, that there's a statement that clinical validation, it is a separate process, and it involves a clinical review of the case to see whether or not the patient truly possesses the conditions that were documented. And so, for example, it's around clinical indicators, the different diagnostic tests such as labs, imaging, as well as the physician's physical interpretation and documentation for their treatment. So if you think about this from a septic patient with septic shock, there are very specific codes for those and at times for those to be assigned. But even if a condition is, and those familiar with the coding rules are when the clinician document that those conditions can be coded. And this is how the clinical validation came along is what is all of the documentation supporting that to truly reflect the severity and diagnosis of the patient. So for instance, with septic shock, are there underlying circulatory, other cellular metabolic abnormalities that are going on? Are there the hypotension and the different levels that are supporting this? So not just one documentation of septic shock, but all the clinical picture being present throughout. And so that is really the clinical validation element too, that is just as important as the specification of those conditions is for there. So all of that is really key for documentation and having that available so it can be leveraged again for these various use cases that we're going to talk about. And how do you leverage technology to support that? Because having watched the documentation evolve from paper into technology in the systems, there is a lot of potential. However, it really has to be around capturing that. And so we will look at the next slide as to how we're going to break it down through to capture a diagnosis from a SNOMED perspective as well as from an ICD perspective. So as you can see, the clinical interface terminology, it does ensure optimal capture, and as well as that leads to the optimal reimbursement. So you can see that the term breast cancer metastasized to pelvis. And so there are multiple codes that are necessary to represent this in different industry standards, such as ICD-10-CM and SNOMED. Each system has its own purpose and its own rules and fundamentals. And so that is why having that available is so important depending on how it's going to be leveraged. So you can see here that SNOMED there's 3 different SNOMED codes and terms that are necessary to actually capture the one clinical idea of breast cancer metastasized to pelvis. And capturing all 3 are important. And so without clinical interface terminology and having that captured in the system most likely would require 3 separate search and selections in order to do that element. So, and each one, go ahead. Sorry, Dr. Cantor.
Sorry, I didn't mean to interrupt. I was just going to say that, as anyone knows from a clinician point of view, it's hard enough to get them to do any sort of clicking in documentation, but to expect them to do 3 things for one specific concept that they want to get across, that is just not going to happen.
Yeah. And then that information is lost if it's not captured and it's not preserved. So it's really important to leverage our systems and technology. So now let's look at the next, the same example, but through the lens of ICD. And so again, as you can see, the same with the same term and then the same codes. However, if you're actually wanting to actually exchange this data and you only have one code that is sent, you can see that a malignant neoplasm going from SNOMED to an ICD directly is the malignant neoplasm of an unspecified site of an unspecified female breast. And so notice the term breast cancer metastasized to pelvis doesn't indicate a gender. However, the assumption from an ICD-10 CM perspective is that the breast cancer is female. So that is why that is the code. And it carries, in this instance, you can see the CMS HCC RAF score of 0.146. But that's just transferring one single code. And again, the rest of the information and the severity of the patient is lost without the additional codes. So, and by using clinical interface terminology, you can see all of the codes are preserved and all of that rich clinical information, not only externally, but internally is available. And you can see the secondary code of the C7989 to identify the secondary site is present, and then there's a higher RAF score because the severity of the patient, they are a higher risk because it is not just a single site of a neoplasm, there's multiple sites, and it's going to require a different set of care than just having a single site present.
So when you think about the way that computer science has developed electronic health records and where they came from a kind of super bill sort of mentality, there was essentially a notion that there was a one concept, one code idea. And so frequently, if you're not careful, although the original documentation within the EHR leveraged the interface terminology, let's say pick the breast cancer metastasized to pelvis, what goes out from the database out to your encoder, for example, may only be a single ICD code. And this is a huge problem when it comes not only in terms of opportunity of right coding, but for all the people who downstream want to leverage that data for things like risk adjustments and clinical trials or clinical decision support, that those missing codes are really very important. So what I think we really want to make sure is happening within your environment, your ecosystem, is that if the clinicians have taken the time, excuse me, to document with that kind of accuracy and that kind of specificity, that we're not throwing away the information that is potential. And because this is not a subjective coding, putting those secondary codes and the additional breast cancer SNOMED codes on this concept are not kind of a subjective thing, but everyone in the country, the 95% of hospitals that are using IMO are having that same translation being performed prior to whatever their encoding step is, that we don't want to leave that information off the table.
Right, because as we'll see next, we'll focus now on the information being left off could impact your claims, the denials and or an underpayment. Here you can see that the denials, that they are on the rise. All of the industry information is showing that the percentage of claims continues to rise, and that here there's an 11% are denied, and that there are actually some that are never reworked or resubmitted. And so avoiding those denials is key to ensure that your facility organization doesn't have to spend any type of manual time reworking the claim, and you receive the appropriate reimbursement that you were expecting and supposed to receive for that, because that leads into the underpayment. And you can see that hospitals receive 86 or 84 cents to every dollar, and for the Medicare and spent on, as compared to 88 cents for every dollar spent on the Medicaid patients. So as you can see, ensuring that you have the appropriate coding on there to reflect the severity and risk of your patients is so important, so that you're receiving all of the appropriate payment, and that process happens through the reporting of these codes. So having all those, as Dr. Cantor suggested, available for those submissions is key, very key. And
You know,
so, okay.
I was going to say that, because I put my other hat on at IMO, which is on that secondary use side of things, and I actually get to see some of this data that is being used, not necessarily for billing, but for their other things like quality measurements and research. What we're seeing is that, not only is this data missing, but there are certain really high priority areas, whether it's in the oncology space or in the chronic care space, where there is frequent miscoding, or I shouldn't say miscoding, but undercoding, where loss of this sort of data. And so it's not like every single diagnosis needs to be evaluated. There are certain high priority areas you might want to focus on.
Yes. And we also realize that it is a whole cycle. And improving that data quality at the source is key to help prevent the manual interventions as one potential solution for the query process to come back. So having that search and select with specificity and ease, and that is native and integrated into provider workflow, that, stating that it can't be under or overstated how key that is for providers, as they have so many things going on in their day-to-days and their workflow, to ensuring that it is, they said, it isn't native within their workflow. And then that also translates to problem lists, and how important to have those simplified problem lists, because again, that is the next step of communication, not only across providers, but with patients, with all of the information going to patients today at a faster pace, ensuring that is appropriate and accurate and quality data is also a key area. And of course, then if your organization is reimbursed by through the risk-based, as the risk-based contracts of a variety of different models continue to increase, focusing on HCCs and CMS in this instance, and help identifying those to ensure, again, that you are able to capture all of the appropriate revenue opportunities. So we'll look at how we can have that specificity secondary code into a native integration on our next slide. Here you can see that there is, from the problem list, the type 2 diabetes. And so if a provider using an IMO solution would like to, the patients coming in, that's part of what they're monitoring and evaluating, that select that. So that type 2 diabetes is very appropriate for a problem list, but as you go through the providers go through the encounter, and there's additional complexity related to the diabetes, then having that information as not only from the clinical, but aligned with what the ICD perspective. As you can see, there are different nudges with the type 2. You can see the diabetes long-term insulin use, the complications, if there's any complications, to help guide or show the physicians that these are different options. And so whatever clinical scenario is appropriate for their patient, that there can be selections along the way to facilitate their documentation. And so then that translates on that visit diagnosis to, you can see 4 different codes back from the original problem list of type 2 diabetes. And so you have the long-term current insulin use, the end-stage renal disease, the chronic kidney disease, which also has a code for dialysis. So all along the type 2 for problem list, and having that available, and then adding the additional specificity for that specific encounter, and having that as part of the natural search and selection that providers are performing will facilitate the capture of this information.
One thing that's really important, because I know that you may be very familiar with clinical documentation improvement and this attempt to sort of get more information out of the clinicians at the point of care, but how you do it really makes a difference. As a clinician, it's important that I'm not seeing this as purely a way to get more billing codes out, but rather this is what's relevant to the clinical care of the patient, and that would be naturally sort of efficiently sort of augmenting my care. So one thing that's really nice about the way IMO and we can do this with this clinical interface terminology is that when we refine the diagnosis or help the clinician refine the diagnosis, we're not doing this just to get ICD codes out. We understand behind the scenes that this is additional level of clinical specificity that has clinical relevance. And therefore, not only are the ICD codes potentially getting more specific, but we're carrying along the appropriate SNOMED codes, for example, so that if you're doing some back-end work on clinical decision support or quality measures for your ECQMs, those are going to also have additional level of specificity. And it shouldn't be asking me things that I've already told it. So if you enter and start with a level, with a clinical concept that actually has more information, maybe we already know that the person's on long-term insulin use, or maybe I already know that they have CKD, the nudges will be incremental. So it's like only there's some additional things that you haven't yet asked me. And so I can start in the middle of this sort of tree and not have to go through multiple questions that I've already answered by where I started from. And I think these are really important things to think about as you're talking about nudging at the point of care, that we do this in a really highly efficient way, and one that is maintaining relevance to the point of care and not just for the back end.
Great point. Yes, definitely. And also at IMO, we realize that there's the front end point of care solutions. We also are aware of that data is flowing throughout the system, and that it is important to take a look at the data also on the back end and as an aggregate, as well as for each individual patient. So there are solutions to reduce that burden of manually cleaning and standardizing that patient data, because the data all has to be in a language for, like I said, for each system that has that purpose for the evaluation. And so, and then to do that at scale and to reduce that burden of manual effort is important along the way. And so taking that and looking at from a revenue cycle, we'll see through there was a large health system did partner with IMO for some diagnosis analytics from their EHR. And at a high level, from that analysis, 2/3 of the analyzed diagnosis were incomplete. And this was either due to a secondary code needed to be present but wasn't, or there was a more specific ICD-10 CM code available for that clinical condition. And so again, thinking of as the data is telling a story and looking at it from start to finish is as another key element for your organizations to consider, is looking at this holistically, and you would see what would be present through that.
So I think June can add to that also in the sense that, not only where's that problem that I had originally mentioned, where even though certain, clinicians did spend the time and did get nudged or whatever to get to the right term, that they were, had more specificity, that somehow in the process of the EHR pumping that data over to the secondary systems, that information was lost. So that's one example of where this normalization engine is really important, to sort of catching it right before it goes into the downstream process to make sure that all the right codes are still there for whatever process you're using to improve quality and right coding, that they have a bigger and more accurate corpus of data. But that there are other places where data is coming into the system. Not only are not all physicians going to take the time to potentially refine their diagnoses, but data that's maybe supplementing from ancillary systems, either through CCDs and other data that's coming in that may be relied upon for things like quality measure. But that data might not have all of the metadata and additional codes that are necessary. And so this normalization process is able to recover at least a portion of the information that might have normally been lost by your system by reassigning it the kind of high-level, high-quality data coding that then has appropriate ICD, SNOMED, whatever appropriate codes fall afterwards.
Right, great point. And, you know, and again, thinking about those downstream is if that data is missing or needs additional specificity, you're back into the loop of the manual back and forth, and potentially missing out on appropriate reimbursement because the code is not making its way all the way through the system, but yet from the provider and the EHR perspective, when you think about how the risk models look at the care for a whole year, is it appears that it's captured. However, if it's not going all the way through to the payer in the instance of risk-based payments, then it's not actually, the payment is not reflective of that care, and that it really needs to be along the way. So.
Yeah, and it's not only are you not getting credit for stuff that you should be, but that when it comes to things like those quality measures, you know, the accurate definitions of those numerators and denominators really depend upon, you know, having complete comprehensive coding. And so you can improve your performance on those by, you know, your numerator, you get credit for things that you actually did, but also you're excluding through exclusions on the denominator certain patients that you normally shouldn't be doing things on that are being included in your measure because you didn't adequately document why they should have been excluded. And so this is a secondary value, not just a direct payment value, but in how those bonuses and stuff get assigned based on your quality measures.
Right. And as the industry continues to transition into value-based care, those measures continue to play a huge role in that conversation. And that actually leads into one of the last slides around the analytics, because, you know, data tells a story, and you want to make sure that you're telling your story and appropriately. And so while you looking at this from the front end and then that back end overall perspective, you'll be able to see were there specific areas or diseases that you know that there's additional clinical information that is not being captured throughout the whole process, such as diabetes, is the type, the different complications, because as you know, those folks well know that those evolve and they change over time, and it is not uncommon for various diabetic patients to have more than one type of complication. Another huge area that it continues to be evaluated for the impact is around obesity. You know, the various types and classes, and what is folks' BMI, and how does that impact, and what risk does that bring to other health conditions along the way. So having that information is so important to really reflect that from that disease specific information. And then that translates to, you know, just a reflection of the overall risk of the patient population that is being managed by the providers, facilities, and how that impacts the risk-based contracts. Because if the data is not telling the story of the severity of the patient, then, you know, having to go back and when providers are negotiating with the payers and there is a risk model being discussed, is how does one know the true risk of the patients without having all that data available? And then that leads to an individual level of where one of the top denials is the services are not covered or not deemed medically necessary, which they very well could be, but it's not being reflected through the system with a code if they're not specific enough or not being captured enough. So it really is important to have the, you know, the data tell that story, and your organizations be the author and editor to really reflect the story of that you is appropriate for your organization.
So I think if you go back to that, so the beginning of our story here about, how these electronic health information systems evolved, and by sort of moving us into a place where clinicians and coders and researchers and quality improvement professionals are all on the same page, working with the same data, and that it's moving toward the same goals of more efficient and higher quality care, and that the way that we're going to get there is you're not there exactly yet, but that there are some tools that we can apply to actually improve this process. And it fundamentally comes down to data quality. And we're not trying to say that we're sort of gaming the system, but we're talking about actually accurately describing what the care is provided, both for the purposes of the physicians at the point of care and for the institutions to be sure that they're properly getting what appropriate compensation for that care. And the database of that information is really powerful to drive things like surveillance, research, and many of the other kind of holy grail uses of health information technology. We've talked about kind of 3 different areas of where this is fundamentally kind of going wrong right now, and where you can potentially have a positive impact. So the first was the point of care clinical assistance. And this is where those kind of tools can be applied at the point of care to nudge physicians to actually be more accurate in their diagnosis documentation, or in general, their clinical documentation. And there's really no other opportunity other than at the point of care, when the patient's really still there in front of them and when they're doing the documentation, to get that right. And so having tools that both serve the clinician by making it easier for them to do their job, but also provides the necessary high quality data to drive everything from reimbursement to clinical decision support and research, can be done more efficiently if we can capture that at the point of care. However, there's this sort of after the point of care opportunity, and this is where normalization comes into place. And so that normalization can take data from multiple different data sources and really ensure that when they're reducing and aggregating that data, that they do it at the highest level of specificity possible, regardless of where the original source code came from. But based on the clinical content of that data, we can essentially make sure that the highest granular data is coming through to your information system downstream. And so this can be both from structured documentation that was brought in that might have been down coded based on just whatever the source system happened to code for, going back to the original structured data. Or it can happen in the annotation portion, where someone, a clinician, might have chosen a structured code, but then actually went on to add additional clinical information in an annotation. That information actually can move the specificity of the code. Therefore, that is a really important step. And then the last step, which I think really is critical for justifying your quality measures, as well as the higher RAF scores, as we've seen earlier, is these missing codes. Literally, where the information systems, although they initially might have captured sufficient documentation to provide multiple codes, simply fail to bring those codes along for the ride. And so this, even though it might only be 5 or 10 or even 8% of the encounters, diagnoses would have required a secondary code. As we've seen with that cancer diagnosis or metastatic breast cancer diagnosis that we talked about earlier, these have substantial benefits in terms of loss of data. So if you think about this as an entire data quality improvement effort that can be done, through both point of care improvements as well as these sort of back end or sort of technological middleware improvements that may improve your data regardless of whether who you're using for your back end encoding and payment models. So hopefully this gives you kind of a perspective that we were trying to accomplish today which is the full breadth of data quality, involves multiple interventions that are possible.
Yeah, and in addition to think about the data quality, the longevity of this, because obviously there are encounters that happen on a routine daily basis, and having that whole breadth of data quality. But then when you think as you're looking over a year, 5 years, the research is, or even internally evaluating your own data and using several different tools for that is really key as well.
All right, thank you both. So at this time, we are going to go ahead and kick off our Q&A session. So if you have any questions that you'd like our presenters to address, please go ahead and enter them now, and our team will start answering questions live. As we are receiving your questions and reviewing them, please just excuse any brief silence while we're looking through.
There is one question around the point of care assistant nudges that you spoke about. They, again, appear to provide that guidance to providers, but do you have any insight onto what the provider feedback is around those nudges? And I'll go ahead and start, is that there, as the nudges, they can happen at different levels. It's not necessarily for every diagnosis, and that is because of the balance, realizing that if there are different clicks and selections, that has to be balanced out with how often that is being presented to the providers. And overall, the feedback is very positive because, as Dr. Cantor spoke about earlier, there are times, depending on a selection, what first appears on the screen as several different nudges can change to one or actually zero, depending on what is selected and where they are. So it is really the feedback that I have heard is an efficient way to navigate through some of the specificity.
There's also times where, you just don't have an answer to the nudge, and like if I'm seeing a patient in my ER and they have new onset atrial fibrillation, I may not actually know what the etiology was for the atrial fibrillation. And so there are times where it's appropriate to document more specificity, and there's other times where it's not.
Yeah, it's a great point, and that's where I think the nudges show that depth and breadth and allow that for them, the decisions to be what is known at the time to be captured. So. Oh, I see another question around, is there a prioritization or a best practice IMO recommends for the solutions that were presented? I mean, do we have to start with one or both at the same time?
June, do you want to also take that?
Oh, sure. Yeah, I can start. There is really not a order per se. It really depends on where your organization is and in their journey. Obviously, best practice is to implement both along the way. However, if there is an area that is a greater need for your organization, then we could start with a back-end solution, or we can start with a point of care. It really is, that's the other nice element around these solutions, is that they can be customized to fit in or with where you are in your process for that. So it's not a whole package at once if you're not ready for all of that, but if you are, that can be done too.
Yeah, I think it's really important that you mentioned that, ultimately to get that full data quality package, you do need the full both prospective and sort of retrospective activities, because you can never further refine or further encode the data beyond what the original documentation supported. So but it is possible, for example, that if you, because we know that there's a huge data quality problem currently, that if you've got a long-term process of improving the point of care, which might involve multiple approvals for anything that touches workflow or clinical care, you can actually start that approval process, but begin with the back end work, which is really a technical improvement, which is part of we actually forgot to mention, June, that all of our maps are AHIMA approved or validated, and that we have just about everybody in the country uses IMO, and so getting those codes back in is a relatively from a technological point of view, sort of a simple thing to be doing. And so you could act quickly on the sort of middleware type aspect while you're going through all of the approvals necessary to get that point of care process implemented.
Yeah, and that's a great point about the AHIMA review and having that, because we do value that relationship and the transparency throughout, because we recognize the importance of those codes being available. So yeah, great point.
It's on our slides, but we forgot to give them credit.
So if there are additional questions, please enter those into the chat.
All right, it looks like the questions are slowing down. So we're going to go ahead and close out for today. The IMO team here really hopes that you found the information in this presentation useful. If you want to learn more about IMO, our solutions, or just continue the conversation, feel free to contact your client executive or email sales@imohealth.com. Thank you all so much for attending, and have a great rest of your day.
Nice talking to you guys. Bye now.